Hello, thank you for watching our recording of the webinar, Effective HPV Vaccine Communication, helping providers and nursing staff make strong vaccine recommendations. This presentation was recorded on July 17th, 2024, and it was presented by Dr. Noel Brewer, who is a Gillings Distinguished Professor in Public Health at the University of North Carolina in the Department of Health Behavior at the Gillings School of Global Public Health. He has a PhD in health psychology from Rutgers University. Dr. Brewer's research examines vaccination, tobacco use, medical screening, and other cancer-related health behaviors. He has published over 375 papers on these topics, including on HPV vaccination and vaping warnings. He's one of the most cited researchers in the world, according to Clarivid. Dr. Brewer is a voting member of CDC's Advisory Committee on Immunization Practices and advises the World Health Organization on the drivers of vaccination. Dr. Brewer leads a center on improving clinical staff communication about HPV vaccination, funded by $12 million in grant funding from the NCI. The center is developing ways to expand the use and impact of the announcement approach training developed by Dr. Brewer and colleagues that teaches providers to recommend HPV vaccine more effectively. Our other presenter is Dr. Jessica Young, who is an assistant professor of pediatrics and the associate program director of the preventative medicine residency at the University of North Carolina at Chapel Hill. As a pediatrician and preventative medicine physician, she is passionate about vaccines, so much so that her colleagues often refer to her as their vaccine champion. Dr. Young leads many projects on health equity and childhood vaccination uptake, particularly for vaccines with higher rates of vaccine hesitancy, including influenza, COVID-19, and HPV vaccines. Dr. Young works with Dr. Noel Brewer's research team as a physician educator and teaches providers and nursing staff across the country how to effectively recommend the HPV vaccine for children starting as early as age 9.
Dr. Brewer and Young, welcome. You can begin.
Great. Thank you so much, Dr. Newman, for that introduction. I'm going to go ahead and share my slides with you all. And we'll get started. Alrighty, so hopefully you all can see my screen. Dr. Newman, please let me know if you can't. But I'm so excited to be here with you all today, joined by my colleague, Dr. Noel Brewer, and we're here to talk with you about effective HPV vaccine communication, and more specifically, talk about helping providers and nursing staff make those strong vaccine recommendations. So before we jump into the meat of the presentation today, we just wanted to review some disclosures. So this webinar today was coordinated by UNC and NDSU. The announcement approach training, which we'll learn about today, was developed with funding from the National Cancer Institute, and we have the grant information listed there with Dr. Brewer listed as the principal investigator. I personally have no conflicts of interest to report today. Dr. Brewer would like to disclose a few disclosures. He is a voting member of ACIP, and he has been a paid consultant for CDC, Merck, Moderna, Novavax, Sanofi, and the WHO. So our desired outcome today is that we want to encourage healthcare systems to lead HPV vaccine communication trainings in their clinics. So to do that, we want to accomplish a few objectives. We want you all to understand the impact of HPV vaccine for cancer prevention, describe those 3 key steps of the announcement approach for HPV vaccine communication, and identify resources for bringing the announcement approach training to your office or healthcare system. And as Dr. Newman mentioned, we'll have hopefully a few minutes at the end. If you all have any questions, we'd love to hear from you all as well. So we'll start out by reviewing some evidence both about HPV and the cancers that it can cause, as well as the HPV vaccine. So HPV causes 6 different types of cancers, as you can see illustrated by this diagram here on the right of the screen. It can cause vaginal, penile, vulvar, anal, cervical, and oropharyngeal cancers. And we tend to think of HPV as only affecting women, but as this graphic here shows, it is also affecting men as well. And in fact, we see if you direct your attention towards the bottom of that pyramid, oropharyngeal cancer has tripled in recent years, and we see that that particularly impacts a large male population. And so the point here is that HPV cancers can affect anybody. And we also know that there are disparities that we have as it relates to HPV cancers. We know that there is higher burden among Black and Hispanic people. And we also know that HPV cancers disproportionately affect people living in rural areas. And so the point here is that HPV and the cancers that it causes are a very important public health topic that we all as healthcare providers should be thinking about. And there are also disparities as it relates to HPV cancers that we need to think about as we learn ways to prevent HPV and the cancers that it causes. So the good news is that we have an HPV vaccine and it is very effective. And so we have a graph here on the slide that I'd like to walk through with you all today, and I'll try to walk through it slowly so we can all be on the same page. So this graph shows at the bottom, or the x-axis, the age when a person would have received the HPV vaccine. So you can see the options of never, they received the vaccine as an adult, or they received the vaccine as an adolescent. And along the left side here, or the y-axis, you have rates of invasive cervical cancer among adult women. So you can see that if you look at those who never had HPV vaccination compared to those who had HPV vaccination as an adolescent, there's a great decrease in cervical cancer. And in fact, in this population-based study, it was found that providing HPV vaccination younger, so as an adolescent in this study, reduced the chances of cervical cancer by 88%. And so the point here is that the earlier that we can provide HPV vaccine to our children and adolescents, the greater chance we are giving them of having that prevention against cervical cancer later in life. And furthermore, not only do we have a vaccine that's very effective, but we also have a vaccine that is very safe. And we've had a lot of studies that have provided a lot of reassurance in this area. And so at this point, we've had over 300 million doses of the HPV vaccine delivered, and we've had about 109 studies of 2.5 million people really looking at and assessing the safety of this vaccine. And the results have been very reassuring that the HPV vaccine is very, very safe. And in fact, the only serious adverse effects were those also seen for other adolescent vaccines, and these tend to be pretty rare. And so we have this vaccine that is both very effective and very safe. And so we have an opportunity to really practice primary prevention and prevent certain types of cancers for the patients that we're seeing later in life. HPV vaccination can start at age 9, and a lot of the work that Noel and I do is teaching people how to start recommending the HPV vaccine as early as age 9. And both the CDC and the American Academy of Pediatrics have both stated that HPV vaccination can start at age 9. So if you have a patient in the age range of 9 through 12, they are considered on time for HPV vaccination, and they would receive 2 doses of the vaccine to complete the series of HPV vaccination. For a patient that is age 13 or 14, they are considered late for starting HPV vaccination. However, they still would receive 2 doses to complete the series. However, if you have a patient who is 15 or older who has not yet initiated HPV vaccination, they are also considered late, and they also will need a 3rd dose to ensure that they get the best and full protection against HPV. And so sometimes we hear from parents that this is reassuring and this is convincing to get the vaccine earlier rather than later, because it will save the child the chance to have another shot. They can have 2 doses instead of 3 doses of a vaccine. And sometimes that's pretty convincing for both the parents and the patient. And so the point here is that, the vaccine is especially effective in younger children. And so we want to push for trying to vaccinate as early as age 9, because it's both, very effective, and we have the opportunity to just do 2 doses instead of 3 doses. And so now that we've talked a little bit about the background and evidence of HPV cancers and also the HPV vaccine, I'd like to move forward and talk to you all about the work that Noel and I do, which is centered around the announcement approach training. And so the announcement approach training, as you all have heard, is an evidence-based approach to teach providers and nursing staff how to strongly recommend HPV vaccine to children and adolescents starting as early as age 9. And so I'd like to give you an overview of a little bit of background of this training, and then you'll have a chance to see some of the components that go into the announcement approach as well. So we'll start off just talking about what is the announcement approach training, and you might hear me refer to this as the AAT. So again, this is training on effectively recommending the HPV vaccine, and it's typically for providers and nursing staff. And we found that this training works really well for both providers and nursing staff and has been equally effective. The training itself typically occurs about 60 minutes and typically occurs within your own clinic and is led by a person with experience in providing the HPV vaccine. And so our hope is that if you are ever attending an announcement approach training, the person that is leading that training is likely a colleague that you recognize from your healthcare system or from your clinic. And we're proud to report that the National Cancer Institute has designated the announcement approach training as a best practice. And so we do have materials available for the announcement approach training. And some of the materials that we provide are script and slides, and that is primarily for our training facilitator, so the person delivering the training, so that they have information on exactly how to present each slide of the training and what to say for each of the slides. And that usually can help the training process go a lot more smoother for the facilitator. We also have some demonstration videos as a part of the training, which you all will have a chance to preview today. And those are scenarios that just allow our trainees to get an understanding of how the announcement approach might occur as a part of a routine well visit that you have with a patient. And then lastly, we also have a flyer that we like to share with all of our participants. And this flyer reviews some of the most common questions and concerns that parents or caregivers might bring up as it relates to HPV vaccine, and also gives our participants some very quick messages to understand how they might want to respond to certain concerns that arise during the visit. And so those messages are designed to be very short and quick and to the point. And then we also encourage our participants to also use their clinical knowledge and expand upon those points to really address the question or concern that the parent is stating for that at that visit. So we're happy to say that there are a lot of benefits that you would get from attending an announcement approach training or the AAT. And there are lots of benefits to clinical staff that I like to point out today. So we know through our research that it has the capability of boosting HPV vaccine uptake by 5%. It can really help to simplify discussions. And what that ultimately does is save you time in the visit so that you can move on and address other important health topics that either yourself or the parent might have for that particular visit. We're happy to report that we found that it increases patient satisfaction. So we found that families and patients actually prefer this type of method compared to some other methods, such as mentioning that there's an option to delay the vaccine, for example, or not recommending it at all. And as I mentioned earlier, the training is equally effective for nursing staff as well. So both the CDC and the American Academy of Pediatrics both recommend using presumptive announcements to recommend the HPV vaccine. And again, that's exactly what we teach in our announcement approach training, is how to really make that strong recommendation using a presumptive announcement approach. And the AAT is used nationally, and it seems like we're expanding almost every day. And so you can see here, this map shows the various states where we've had the AAT delivered. At this point, we've had over 3,000 clinical staff in 20 states where we've had the AAT delivered. So again, it's widely accepted. People seem to really enjoy it. And again, it's expanding almost every day. So we hope that if you're here representing a different state that's not here on the map yet, that we can hopefully also incorporate the AAT as a part of your healthcare system or your clinic if you are interested as well. And so I've kind of alluded to this already, but we do have high satisfaction with the AAT, not only with, again, parents and providers, but our clinical staff, our providers and nursing staff seem to really enjoy the AAT. And actually 100% of attendees would recommend this training to a colleague. So it's a pretty high number. You can't get any perfect than 100%. And then 93% plan to routinely use this communication strategy. And so the people that attend our training seem to really enjoy it and find it really helpful. And in the words of one provider that attended our training, it's easier for parents, it's easier for us. And so now that I've given you some background on the announcement approach and hopefully have gotten you really excited to hear more about what the actual approach really is, I want to preview with you the key steps that go into this approach and give you an idea of the type of training or materials that we use in our training and the things that we teach as a part of the announcement approach training. And so the announcement approach really consists of 3 key steps. The first step is announce. If a parent hesitates, then you move to the second step of the approach, which is connect and counsel. And if a parent declines, you move to the third and final step, which is try again. And so I'd like to dissect each of these 3 steps with you to give you an idea of the key components that go into each of these. And so again, the first step is called the announce step. And here you do a few things. First, you want to note the child's age. And this really keys the parent that what you're about to say and what you're recommending is really a part of routine preventive care. You also want to announce that children this age get a vaccine that prevents 6 HPV cancers. And we know that discussing what the vaccine prevents, the diseases that the vaccine prevent, is very important for the parent to hear, more so than just speaking of the vaccine names themselves. It's very important to talk about what those vaccines prevent. So in this case, it's very important to discuss the prevention of those 6 HPV cancers. And then it's very important also to say that you will vaccinate today. And we know through research that it's important to emphasize today because that is more likely to lead to vaccination versus mentioning the option of delaying, for example. So here's an example of what the announce step could sound like. Alex is now 9, so today they'll get a vaccine that prevents 6 HPV cancers. And so you can see the announce step can be short, sweet, and to the point. And this does a really great job, the example here, of incorporating still those 3 key elements that we just went over. So at this point, if the parent agrees to HPV vaccination, you can move on with the rest of the visit and address other important health topics for that day. However, if the parent hesitates or has a question or concern, you want to move on to the second part of the announcement approach, which is the connect and counsel step. And so we'll break this down by first talking about the connect portion, and then we'll talk about what the counseling portion looks like. So for the connect portion, it's really important that you ask the parent for their main concern and really understand what is their concern or hesitation about the HPV vaccine today so that you know how to most appropriately address whatever concern they have. And to show that you're listening, is really important to repeat the parent's own language. And this is really getting at some of those motivational interviewing techniques and the importance of reflective listening. And so an example of what this could look like is, what would you say is your main concern? Well, I thought that they wouldn't need any vaccines for a few years. I hear you. You didn't expect Alex to be getting vaccines at this visit. And so you can see how that interaction with the parent in this example really, again, practices those reflective listening techniques and uses the parent's own language to restate what the concern is. And so then you want to move on to the counseling portion of this step. And so here it's really important to address the parent's concern using a research-tested message. If you recall earlier, I mentioned that all of our participants of the announcement approach training receive a flyer with those most common questions and concerns that come up as it relates to the HPV vaccine. And so that's a really good resource for our participants to have to have really quick responses to think about what they might want to say to parents when certain concerns do arise. And again, we do encourage all of our participants to use their clinical knowledge to expand upon those quick messages that we give them as examples as well. And then it's important to, again, reemphasize to get the vaccine today and give a reason for doing so. And so let's go over an example of what the counseling portion might look like. The American Academy of Pediatrics recommends that kids get the HPV vaccine starting at age 9 to prevent 6 cancers. I strongly recommend Alex get it today because the vaccine works better when given younger. So here you can see this response is tailored to whatever the concern the parent had. And they also kind of re-emphasize the importance of getting it done today because the vaccine works better when given younger. And so say you did your announced step and the parent had a question or they hesitated in some way. And so you connected and counseled and you did a great job with that, but the parent ultimately still declines the HPV vaccine for that day. And so the point here is that we want to give some opportunity for some back and forth discussion about HPV vaccine, but it shouldn't encompass the whole visit. And so if the parent declines, then you want to move on into the third step of the announcement approach, which is the try again step. So here you want to make sure that you let the parents know that you will bring up the HPV vaccine at the next visit. And this kind of lets the parents know that you feel that this is important for their child. You feel that getting the HPV vaccine is very important for their child's health. And so you want to tell them that this is something we will keep talking about and something we can continue to have conversations about. And lastly, you want to be sure to make a note in the chart. This can be really important, especially if you work with a lot of colleagues or you work in a busy clinic and you and your colleagues are often seeing each other's patients. This can also serve as a communication tool to let your colleagues know if you recommended the HPV vaccine and kind of what the outcome of that conversation was, so that they understand how to then come in and kind of pick up that conversation and hopefully use evidence-based approaches like the announcement approach to re-recommend the HPV vaccine upon a later visit. And so those are the 3 key steps of the announcement approach. Again, we should have time for a Q&A a little bit later, so toward the end of our talk today. So if you have questions, we'd love to address them at that time. If you have questions about the announcement approach or any of the materials that are presented here. But I am going to go ahead and pass it on to my colleague, Dr. Noel Brewer, who will walk us through some of the updates that we've had for the AAP over the most recent years. Thank you.
Thank you so much, Dr. Young. So I'll be talking about the updates we've made to the announced approach training. Many of you on the call have seen some version of this, either quickly in summary, or maybe even some of you have attended the trainings, but it's evolved over the years to reflect the best research evidence that's available, as well as to just sharpen it and make it better. Next slide. So one of the things that we did is we modified the structure of the announcement approach itself. We wanted to reflect the current evidence that having connecting and counseling in separate steps wasn't meaningful to clinicians and nursing staff, that they, and also especially parents, that those steps tended to blur together a little bit, trying to figure out how to connect with a parent and sort of address their questions, as well as to recommend the vaccine and saying you should get it, the counseling part. So all of that's now combined into a single step. In addition, research suggested that a good number of parents will be open to the vaccine after they've said no, or they've said maybe, or they said another day. Indeed, of the people who say no or who decline the vaccine in whatever form, 3/4 of them will have gotten the vaccine a year from then, or at least intend to. And that's a really important detail. So no is just no for now. Let's keep talking for many parents. Next, thank you. So another important change is the focus on the focus on age 9. There's a national push to start HPV vaccination just a little younger than we have before. We used to start HPV vaccination at 11, and as a result, many kids didn't get it till 12 or 13 or even later than that. The vaccine is more effective at younger ages. It avoids weird conversations about sexual or about sex and whether the vaccine is, can cause people to become promiscuous and all that. Data show that it absolutely cannot. It's also not a main concern of parents, but somehow it some providers and maybe some nurses still have that as a concern. So another thing is that the announced step focus now focuses solely on HPV vaccine at age 9. So you have two different approaches, one at age 9 and 10, and another at age 11 and 12, which is a little more like the bundled approach that we used to take. And I'll give examples of those in a moment. Next. We have an expanded focus on DEI. We highlight the impact of HPV and HPV cancers on Black, Hispanic, and rural communities. We heard some of those data earlier when Dr. Young was speaking. We give an announcement for a non-binary patient. We use the names for children that are common in multiple racial and ethnic communities so that it's more inclusive of the people in the room. And finally, we include a Black family in the demonstration video. You'll see one in just a moment. So these demonstration videos, as I said before, demonstrate something important. There are two different announcement approaches. One for younger ages that focuses just on HPV vaccine, which is helpful. That's one of the main benefits of age 9 is that you're able to talk about HPV vaccine without having to deal with Tdap and meningitis vaccine. What happens is that maybe even over a quarter of providers will only give up to 2 vaccines at a visit. And when you have meningitis and Tdap being required in many schools, in many states, then you crowd out the space and HPV gets pushed off to last. By pulling HPV vaccine earlier, then you have a better chance of being able to get it delivered without being crowded out by other vaccines. And then you also have a moment to relax a little bit. So if you don't get it at age 9, fine, you're going to get it at age 10. And maybe even if need be a little after that. So I'm going to go ahead and play this first video so you can see what the announced approach sounds like that Dr. Young shared with you.
Now that Marcus is 9, it's time to get started on a vaccine to help protect him against 6 HPV cancers. He'll get his first dose today and his second one at his next checkup.
HPV vaccine for a 4th grader? Wow, I wasn't expecting that.
Okay, it sounds like you have some concerns about that. Can you tell me more? What would you say is your main concern about the HPV vaccine?
Isn't he too young? My older daughter didn't start that one until she was 12.
I hear you. It is hard to believe that Marcus is old enough for the HPV vaccine. It probably seems like just yesterday you were doing his booster vaccines to get ready for kindergarten. But 9 is actually a great age to get started.
Really? Why is that?
Well, for one thing, kids have a stronger immune response to the HPV vaccine when they're younger. That may give them better protection against HPV cancers later on. Another advantage to starting now is that Marcus still has plenty of time to get both doses at his regular checkups. That way you don't have to bring him in for extra checkups.
Okay, if you think it's time, we'll go ahead and get started.
Great. So Marcus will get his first HPV vaccine today. At his next checkup, we'll give the second one, and then he'll be all set.
Yeah, so what you just saw there was a pretty agreeable interaction. A little bit of questions. Parent was a little hesitant, but not a really strong level of hesitancy. Everything ended well. Didn't even need to do the try again step because it all wrapped up. You heard also information about HPV vaccine being more effective at preventing disease when given at younger ages. It creates a stronger immune response. It does appear that giving it younger may be better. It may be better at preventing disease, although the specifics of what you define as younger, whether we're talking like 9 to 14 versus an older category and so on. I mean, there are discussions to have about that. So it's not fully established that it's better at cancer prevention when given younger, but it does seem to be better at other kinds of disease and certainly better at preventing infections. All right, so that's age 9 and 10. It focuses on HPV vaccination and it focuses on that one piece. So now at age 11 and 12, it's a more complicated space because you have these other vaccines jockeying for attention. Now, I will say that this demonstration video doesn't deal with COVID or seasonal influenza vaccination. So there's even 2 more vaccines that could sort of be part of this conversation. But for right now, we're going to focus on these 3 vaccines. And you'll see this parent has some stronger concerns. So let's see what this looks like.
Now that Sophia is 11, it's time to give her vaccines to protect against meningitis, HPV cancers, and whooping cough. We'll give those at the end of the visit.
Yeah, I know she needs to get some vaccines before school starts, but HPV vaccine? I don't think we need that one.
Okay, It sounds like you're not sure about the HPV vaccine. Would it be okay if we talk more about that?
Yeah, okay.
What would you say is your biggest concern?
I've seen some bad stuff online, like that HPV vaccine can cause infertility and that kind of thing. I just don't want to risk it.
It makes sense that you'd be concerned about those stories. The good news is that researchers have conducted over 100 studies on the safety of HPV vaccine. They've consistently found that it's really safe, just like the other vaccines we give at this age.
Okay, but what about fertility?
Many studies have looked specifically at fertility, including ovarian health. The findings are reassuring. There's no evidence that HPV vaccine causes infertility or any other reproductive health problems. What can cause infertility is cervical cancer, which Sophia would be more likely to get if she's not vaccinated.
Yeah, I don't know. I just don't think the HPV vaccine is right for our family. I would need to talk to her dad before making a decision like that.
I hear you. Today we'll do the Tdap and meningitis vaccines. I'll put a note in her chart and we'll revisit the HPV vaccine at her next checkup after you've had time to talk to her dad about it. I want Sophia to have every opportunity for cancer prevention, so let's keep talking about it.
Okay, that sounds good.
So a lot of good things happen in that interaction. I mean, the vaccine wasn't delivered, and that's fine. The parent can decide no, that's their option as parents. But it was a pretty warm conversation, even though they were not agreeing on the next best course of action. There was a focus on cancer prevention. That was really good. Early on, when talking about HPV vaccine, they didn't focus on vaccine names like Tdap and so on. Instead, they talked about what's prevented. The healthcare provider said, your child is due for vaccines that prevent meningitis, HPV cancers, and whooping cough. That's a best and recommended approach. Another thing is we often recommend starting, if you have the three to talk about, starting with meningitis, because it's the thing that parents somehow key into and really see as scary. Then cancers are definitely something that concerns them. And then finally, there's no version of Tdap or any of the ingredients that's going to get anyone excited. So we picked whooping cough, and the evidence seems to suggest that that's an adequate way to go. But in that order, meningitis, HPV cancers, and whooping cough. Next slide. So we're still in the section of talking about updates. So what's new in the announcement approach training? We have a technology-assisted practice session where we deliver via people's phone a vignette that says you're either a nurse or you are a healthcare provider. And then the other person in the pair, people pair up and have this practice session. The other person in the pair will role play a parent who has a concern. And then they will do that. The technology-assisted practice session helps people write their announcement. It helps them get access to the flyer that also gives examples of things to say when a parent has a concern about various topics. Next. We also have a facilitator orientation that we've developed that reviews the evidence behind the training and that builds facilitation skills and understanding of the facilitation logistics. So for the people who lead the announcement training, we try to get them up to speed. We no longer do that at the University of North Carolina typically. I mean, we have Dr. Young, who's become a bit of an expert in it, but she leads the facilitator training. So we use this train the trainer model, often working with large healthcare systems, but we'd be happy to also help people who are part of one or two clinics become expert in leading the training, and they can do it in their clinic, and maybe they can do it for colleagues' clinics as well. Next slide. I'd like to thank the team who were involved here, especially Dr. Gilkey and Dr. Young and others who are listed here, who helped with the updates. Next. So now, how do you put the announced approach training to use? Next. I'd like to give you a couple testimonials. The first one is from Dr. Ken Alexander, who is the chief of the Division of Infectious Diseases at Nemours Children's Health in Orlando, Florida. And he had some things to say. He's led the training. The announcement approach makes the communication process shorter and more efficient. It makes us more willing to advocate for vaccination, and it gives the whole process a more positive tone. Another benefit that we see is that we see more families making the right decision to vaccinate. It's a great project that's also a lot of fun. Having led the training for several groups, I can strongly endorse it as a teaching opportunity and as a learning opportunity. Next. We also have the healthcare quality improvement perspective, the system perspective. And this is from a colleague in one of the larger states who we worked with across over a dozen clinics in their system. It was a huge deal for our healthcare system and clinics, not only for all the education it provides, but it has also been a great team building exercise. The research team encouraged us to make sure everyone was given the opportunity to speak up, so our MAs, LVNs, and RNs, as well as our providers, are talking and engaged. Next. So the way to do this, the mechanics are you eventually will interact with us to get some materials, but you also really need to interact with your folks. And if you're part of, if you're in a clinic that's part of a system, you'll meet with the senior decision makers in QI. You'll also identify a champion to serve as the announcement approach training facilitator. You'll also need a staff person for administrative support and just to sort out all the logistics. To host a workshop in your clinic, you'll then attend a facilitator orientation. This facilitator attends that orientation. You'll get our materials, we'll send them to you free of charge, and then you'll plan the logistics and you'll have a great workshop. I will say this, the first one's always a little nerve-wracking and you'll be okay, but you won't be amazing. But on the second one, you're gonna be pretty great. And by the third one, you're rolling and you'll be having a lot of fun. Next slide. So there are some questions. One is, how can I access the material? You're going to go ahead and email us at this address, aat@unc.edu. And a question that we often get is, do you offer continuing education credit for the workshops? We cannot offer it on your behalf. When we're doing it for clinics in North Carolina or as part of our research, we always do. And I really want to underline that it's important to have continuing medical education at CME as well as continuing nursing education. 3/4 of the people who attend announced approach trainings are not providers. They're nurses and assistants and other people involved in the clinic. So when we offer, here's an example in our recent trial, we have had several hundred people attend our trainings in the last year, and about half of them claimed medical education credits and the other half claimed nursing education credits. So if you're not offering CNEs, you really missed a motivator and also something of value for your staff. So to lead an AAT workshop, do I have to attend a facilitator orientation? You don't have to. You can do whatever you want. I mean, you're going to have the slides, you're going to have the script, you can do really literally anything you want. But we suggest you do if you can. As we said before, you'll email us for scheduling at the aat@unc.edu. Next slide. All right, so we're going to move into our Q&A session. Any questions you have, we'd be happy to entertain them. We have a good chunk of time. I tried to go a little quickly through my section. I'm also going to add that any question you have about HPV vaccine is fair game here. I'm happy to answer whatever questions, Doctor, from a behavioral scientist perspective. But also we have Dr. Young here, who has a lot of clinical experience of varying sorts, talking with patients and parents. So let's open up the Q&A.
Thank you so much, Dr. Brewer. There is one, we've had a few questions come in. There's one in the chat here I'll just start with. If HPV is started at age 9, should the child return 6 months later or get the second dose at 11-year-old vaccines?
Dr. Young.
Yeah, thank you for that question. So the minimal interval is 6 months in between like the first and second dose. And so you certainly can offer for them to come back to get that second dose. After that, I can tell you what we typically do because we start at age 9 in our clinic. Usually we will provide the second dose at their 10-year-old well visit, or if they're getting it at 10 years old, we would do it the second one at the 11-year-old well visit. So it may become a little bit more important to think about that shortened timeline if they're a little bit older, especially if they have to do the 3 doses. But typically we will offer the second dose at the next well visit in a year. But there are different options depending on what your clinic and your healthcare system prefer. And of course, what the patient and the family prefer as well.
And the key thing is do what works in your clinical flow as well as for the parents' convenience. There's may not be any clinical benefit to doing exactly 6 months. It may be even better to wait just a little longer to the 12-month visit. There is some clinical evidence showing that the little longer interval might be better.
Excellent, thank you. We just had another one come in here. The HPV vaccine is HPV 9-valent, so why do we state that the vaccine prevents 6 HPV cancers?
The HPV vaccine, HPV 9, so it's the non-valent vaccine, has several cancers in the label that it prevents. So it definitely prevents cervical cancer, vaginal cancer, vulvar cancer, oropharyngeal cancer. It probably also prevents penile cancer. I'm sorry, of course, anal cancer is in there as well. Penile cancer, I don't remember if it's in the label. I don't think it is. But so those are the 6 cancers that we know it prevents. There are not other cancers that we know for sure that it prevents. There's some speculation about some others, but it's not currently there. Of course, the vaccine is also going to be preventing genital warts as well as RRP.
Yes, thank you. Another question for you too. What type of healthcare practices have implemented the AAT? Public health clinics, private practices, large health systems? What have you guys seen?
We've seen a little bit of everything. So we focus a lot on large healthcare systems because they have the right apparatus to train people up. And as I said, it's a little better when you do a few of these. If you do one, you're still kind of getting your feet. And then by the second and third time, you're really rolling and doing good with it. You're doing especially well with it and having fun. But literally any of those things that you said would work. FQHCs, a small one provider clinic is going to be a little hard. It isn't going to make as much sense, but it's not impossible. If you're a solo provider clinic, you definitely have nursing staff there, and you may have colleagues, and maybe the bunch of you want to get together and have a training. That's also a possibility.
Great, thank you. What are either of your thoughts on children only needing 1 dose of HPV vaccine? I know this is potentially something ACIP is looking at next time. Other countries are giving just a single dose. Thoughts around that?
Dr. Young, what have you done clinically?
Yeah, I'll start. And Noel, I know you are more into kind of the research on this topic, so feel free to pick up. We still follow what is currently recommended by the CDC and ACIP, which is, kind of what we reviewed earlier, those 2 doses before age 15 if they're initiating before that age, and then 3 doses afterwards. But we have been hearing some potential 1 dose recommendations potentially coming down the pipeline. But for right now, we're still following our, what is clinically recommended. I will say that knowing that there is potentially some evidence forthcoming about 1 dose being sufficient, it makes me feel good when I can at least get 1 dose into a patient, knowing that that might be an acceptable recommendation at some point in the future, but the official recommendation is not there quite yet. Noel, did you have anything to add?
Yeah, I think we know that the most important dose of HPV vaccine is that first dose. It does a lot. And we're really talking about what about that second dose or maybe a third dose. And for people who are immunocompromised, of course, we're talking about 2 or 3, we're talking about 3 doses. So then there's most people. We live in the US, we have clinical guidelines, and the clinical guidelines are for 2 doses by age 13. And then if you miss that mark, then you're talking about 3 doses because the vaccine may need a little extra oomph to it. So if you've been waiting, and then of course it goes on, there's you can give it as an adult, but we really want to give it from ages 9 to 12. We have clinical data that's going to be coming, clinical trials. There's the Escudo trial, I think in Costa Rica. Those data should be available in 2025 or 2026. So ACIP will definitely be considering those. I sit on the HPV vaccine working group that's just being constituted in part to look at those data. In addition, the company that sells the vaccine is manufactured in the U.S. That's sold in the U.S. They have announced plans for a trial. I will say that I think it's kind of a nightmare scenario if some clinics are giving only 1 dose and other clinics are giving 2 doses. We don't know for sure whether 1 dose, how it goes. I think it's very likely that 1 dose is all we need. If we were in a low-income country or a middle-income country where there were very limited healthcare dollars, we have limited healthcare dollars, but much more limited than what we have. I think I know what my answer would be, but we're not there. We're here. We do have the resources, and we don't want to have this weird patchwork of people just making up the rules. When people switch from one clinic to another, we need to have some kind of standardization. And so following the clinical guidelines, including the recommendations of ACIP as well as what's in the package insert, that's where we should go. So right now it's 2 doses, ages 9 to 12, and that's great. That's a good clinical practice.
Great points. Okay, here's another question. We provide VFC vaccines at our local health department. We have local healthcare providers who send children to us for shots with a prescription. It will only say Tdap and meningococcus. So to the parents who only want to do those, what the doctor ordered, how would you get the healthcare providers to order the non-mandatory vaccines such as HPV or hepatitis A?
I have to think about this for a moment. We have a standard answer to parents who say, well, I just want them to have what's required. And then the answer is, well, I'm your healthcare provider, or, if it's a nurse, we're in charge of your health, not the folks who are running these laws. And those laws also take a while to get updated. We want your child to be protected against these things. And this is a vaccine that prevents 6 cancers and is more effective when we give it younger. So we'd like to do this. So this is important. What do you think? It sounds like some version of that. Now, if you have healthcare providers who are a little behind the times, maybe it's time to have an HPV vaccine push where you can get them up to date on the age 9 issue, as well as on getting all the vaccines so that they can write the full amount. And then if the parent doesn't want it, that's a different thing. But either you're getting boxed in, is what you're saying, and I think the healthcare providers need to know that as well. I will also add that a really helpful thing in these kinds of promotional efforts with healthcare providers and nursing staff is to include a cancer survivor, someone who's experienced the cancer or had a family member die. They're very powerful spokespeople. And so if there's someone in your area who can be that spokesperson, I strongly encourage including them.
Wonderful. Kind of a similar question. How did AAT work with MI training? They seem similar. I assume AAT can work with all vaccines, not just HPV.
Yeah, so like we discussed, a lot of the things that we teach in the AAT kind of pull upon those motivational interviewing techniques. So their motivational interviewing itself, is its own kind of separate topic, and it's much more expansive than the things that we might cover as a part of the AAT training. But you definitely get some practice and experience with using particularly like those reflective listening skills as a part of the AAT. And then to answer the second question, this is something we talk about often with our participants, and I always like to hear like what are other areas in your field where you might use presumptive approaches. And so we think about other times where we might recommend certain screening tests or other vaccines. And so while the AAT does specifically focus on HPV, because that's what the research has put into for HPV vaccine, this can be a beneficial approach to other tests or vaccines that you might recommend as well. And so I can tell you my own kind of what I do clinically. I try to approach other recommended tests and vaccines the same way I do HPV vaccine, because the principle is that you want to provide that strong recommendation and kind of cue the parent in that this is routine for what we do at this age. This is what I offer and what I recommend to all of my 12-month-old patients. This is what I recommend for all of my 13-year-olds. And so I tend to follow that same kind of foundation that the AAT teaches in other aspects of the care I provide too.
Yeah, I'll agree with everything Dr. Young said. One of the things about the announced approach is that it is evidence-based. So we have a clinical trial as well as various implementation trials showing that it works and increases HPV vaccine uptake by around 5 percentage points for a 1-hour in-clinic intervention. That's pretty amazing. It's a cool thing. Now, motivational interviewing does not have trials level evidence. There's a lot of things that suggest that it probably does work. It certainly doesn't hurt. I mean, I'd be surprised if it does, but it doesn't have RCT level evidence. Another thing I'll point out is that there are 4 main strategies taught in motivational interviewing. There's open-ended questions, affirmation, reflection, and the use of summaries. So this reflection idea we use in the announced approach training, and the other ideas are fully congruent with motivational interviewing. So I don't see any problem with it. But what the problem with motivational interview is, what I have seen is that the shortest training takes 2 hours, and a real solid training would probably take, it does take 3 days to 2 weeks. So it's a powerful technique that's designed for things like addictive behaviors, addictive gambling, problem drinking, smoking. That's great for MI, but for vaccination, you can often use a lighter touch thing along the lines of what we've described. And to the other piece of the question, can you use the announcement approach for other vaccines? Absolutely. A solid, great idea. It's used all the time for childhood vaccines when you're talking about vaccines for a 2-year-old. You just do. You talk to the parent a bit. You already have this routine down. You just kind of roll through it. But once you get to adolescence, people lose track of that way of talking in a presumptive way. Turns out that's what most parents want. And then for those who don't, then you slow down and have the back and forth.
Thank you. What are your thoughts about vaccination after age 26? How would you counsel these patients requesting this vaccine with no history?
Dr. Young, as a pediatrician.
Well, my disclaimer is that I don't typically see patients past 21. So that's not typically a conversation that I'm having. I can say, just with what I know and conversation with some OB/GYN colleagues, that the official recommendation, I believe, ends at 26. However, there is an option to discuss with your healthcare provider if the HPV vaccine might be beneficial for you. I just don't know that we have enough evidence or research to support how effective it might be after age 26.
Yeah, so it's on the package insert for ages 27 to 45 years as being possibly effective. The question mark comes around the cost effectiveness modeling. So across the population, it's not cost effective. But for you as an individual, depending on what your history is, it might make perfect sense. That's why it's something where it's considered shared decision-making with the healthcare provider. I'll give an example of a friend of mine who was at 19, got married, was with her husband for 19 years. They were monogamous. I mean, she was monogamous. Who knows what his deal was. And then he sort of hooked up with someone else. And she suddenly was single or soon to be single and didn't know what to do and came and asked me. And I said, girl, you got to go get it. Like, given your history, you seem like a perfect candidate for this vaccine. So whether or not I'd go and do a big campaign for it, I don't know. But as individuals and as as her friend, I absolutely said you should. I would totally, if I were you, I'd be getting it tomorrow.
Great example. This kind of segues to another question we had come in. Is there any potential for the age limit to be increased beyond age 45? Is that something you guys have heard about?
Let's just not.
Okay.
I'm not saying that you can't, and people can do whatever they want to do, but we need to get this vaccine to the folks when it really matters. And maybe there's some risk groups for which this makes sense, but the data are getting pretty thin at that point. Let's focus on getting, as you're getting older, you're going to need shingles vaccine and some other things, and keep up with your COVID vaccine.
Makes sense. Okay, I believe we know the answer to this, but will it ever be recommended for individuals who have only had like the quadrivalent HPV-4 vaccine to receive a single dose of the 9-valent vaccine?
Jessica, what are you doing on that these days?
To be honest, I don't know that I have
Don't mean to stump you here.
encountered that situation.
Yeah, the recommendation currently is to just continue. Whatever vaccine you got initially, just continue with the new vaccine. There are lots of side conversations people have had about whether you go and get 2 doses and so on, but continue the schedule is the recommendation as I understand it.
Yeah, I would agree. As a pediatrician, I believe there's maybe marginal benefits, but not enough to justify revaccinating.
The more complicated one is if someone got only the 4-valent and then they got fully vaccinated and then they're now 25 years old, and do they get the 9-valent? And that's really kind of up to them to decide. It's a small benefit, but there probably is some benefit.
Sure.
And that's not really part of clinical guidelines, and that's very much your decision.
Right. There's been a couple of questions, so I just want to give you guys a chance to reiterate this. Is there a cost for your training or for the AAT program?
All free.
Okay.
Completely free, and there's a script that's word by word. We really ask you to read at least for the key parts of it, like really read that thing. And so you have to learn how to read a script and really kind of sell it. But the script is there, the slides are all there. There's this cool flyer. There's a survey that's programmed that people will just go to. It's a whole package that's ready to go. Just you have to train up a little bit.
Excellent. All right, maybe we'll end with one more here. What do you each think it will take to eliminate cervical cancer in the United States? Higher vaccine rates, screening rates, or something else?
Well, I am definitely, and no surprise, because I'm here, kind of helping with this talk, but I am definitely an advocate for any primary prevention that we can do. I think, speaking from kind of a health equity lens too, as I do a lot of work in health equity, I think it's important to focus on those primary prevention strategies. And so, because we have a tool that has been shown to be very, very effective against preventing HPV-related cancers later in life, I would push for vaccinating as many children and adolescents that we can get vaccinated. I think that has been shown in kind of some of the large population-based studies that we went over earlier in our slides, shown to be very effective. And, it's to me, a low-hanging fruit, something easy to do, something quick to do that can really have a good long-term impact and outcomes for an individual and at the population level. So I would say push for primary prevention and really work on improving vaccination across the country.
Yeah, I'll agree with that. We have this vaccine gives us this extraordinary opportunity to think about the near elimination of a cancer. So we're talking about the near elimination of cervical cancer to below 4 cases per 100,000 women per year. And that's a goal that's been set by the World Health Organization. They've established 3 things that we need to do. We need to get vaccination rates up and over 70%. We need to get vaccination over 90%. Screening rates up over 70%, and then follow up when there's abnormal paths. We need to do that. Without the HPV vaccine, it wouldn't be possible to get to near elimination. So that's good. The modeling shows that one of the most important things we do need to do is to get screening rates up in the U.S. to get women more reliably screened, and HPV testing is increasingly part of that plan.
All right, thank you for that. In our final minutes here, we would just like to again thank Drs. Brewer and Young for an incredible presentation. For those seeking 1 credit of CE, please follow the link provided in the chat to take the post-test and complete your evaluation. This must be completed to acquire credit. And again, a recording of this webinar will be available on the NDSU CIRI YouTube channel. Just want to remind folks, CIRI has a number of other educational opportunities that we'd like to share. First, we're excited to offer a free 4-part online video training module designed to boost clinicians' confidence addressing vaccine hesitancy in the medical encounter. Upon completion of our 4 videos and corresponding quizzes, participants are eligible to claim 1 free continuing education credit. So you can scan the QR code on our screen here and follow the link in the chat to learn more about this opportunity. And then second, as part of CIRI's new monthly webinar series, Boost Your Knowledge, empowering providers to make confident vaccine recommendations, we have Dr. Rebecca Bakke, who will introduce the history of the vaccine hesitancy movement, provide strategies for building trust with hesitant patients, and examine case examples of conversations in the medical encounter. We'll be giving this talk twice. It'll occur on Wednesday, July 31st and August 1st, both from noon to 1. Everyone is welcome, and this activity has also been approved for 1 free continuing education credit. So you can register for that on our website. Thank you all for joining us, and we hope you have a good rest of your day.